When I was 33 years old, I finally got pregnant.
Certainly when I found out I was pregnant, we were over the moon.
I wanted to be a mother my whole life. I was obsessed with I can't wait to get pregnant and have kids. I just always wanted that.
Heart disease and stroke were not even on my radar.
After the birth of my second child, I discovered that I had peripartum cardiomyopathy.
I remember sitting there and the doctor's like, so you have cardiomyopathy, your heart is failing. And I turned and I was like, what? I never even thought of that.
I am a survivor of peripartum cardiomyopathy, which is pregnancy-induced heart failure.
When I was 37 and a half weeks pregnant, I had an aortic dissection in my ascending aorta.
I was diagnosed with peripartum cardiomyopathy and I survived a stroke.
I so quickly realized how fragile life is and how hard pregnancy is.
When I was in the hospital, I was so sick. I just wanted to get home and I wanted to take care of my kids.
I spent the next several days crying, thinking that I was going to leave my 6-day-old daughter.
And she said, your worst nightmare is coming true. You're having an aortic dissection. Today is baby's birthday.
At the time of my son's delivery, I was scared. I thought something was going to happen. I was going to die, and I just wanted to see him.
She asked us if we had to choose between you and the baby, who would you want to choose? Nobody should have to answer that question, especially at 33 years old.
And when the doctor showed him up to me, and I was like, oh my gosh, he's perfect. It was worth it. This was totally worth it.
I was able to have a C-section and an open heart surgery on the same table.
What I had could have been prevented.
Women's bodies go through so much strain during pregnancy.
This has forever changed my life, and all I want to do now is to be able to help someone else.
I had to get up. I had to get moving. I had a young son. I needed to be at my best.
It's okay to put yourself first because you want to be your best self for your kids.
Women that are pregnant at any age need to make sure they are aware of what is going on with their heart.
As time went on and, my child gives me hugs and stuff to this day, it just feels like I wouldn't trade anything in the world for this. This was meant to be.
Through this journey, I joined a club I never wanted to join, of women who had heart issues when they were pregnant. But don't let this fear rule your life. Take care of your heart, take care of your mind, take care of your body, and enjoy every single day you've been given.
Good evening. I am Pamela Garman Johnson, National Vice President of Health Equity and Partnerships and the National Executive Director for the National Hypertension Control Initiative for the American Heart Association. Welcome. The American Heart Association began this series of roundtable events earlier this year with the aim of shedding light on topics critical to the health and well-being of women of color. In February, we hosted the women leaders of the Divine Nine and the Links Incorporated to share their journeys during the COVID-19 pandemic and the impact it had made on the lives of Black women. In March, we discussed the ways in which opioid misuse is affecting communities of color and why women and people of color experience health inequities due to the lack of training in CPR. In April, we talked about mental health and how women of color can build resilience in the midst of the COVID-19 pandemic. This week is National Women's Health Week, and we want to move the conversation to maternal health and how women of color overwhelmingly bear the burden of maternal mortality in the United States. To get us started, I have the pleasure of introducing you to the American Heart Association's Chief Executive Officer, Nancy Brown. Nancy?
Thank you, Pamela. It is such an honor to be here this evening and to be part of this incredible series that we have been hosting, as Pamela mentioned, over the past several months. We are so grateful to you for joining us tonight. We know we will have a compelling discussion with some really amazing champions for women's health. The American Heart Association has long advocated for awareness, education, and research so that women can live longer, healthier lives. Our priority is to reduce the risk and the challenges that women face, like maternal health, recognizing their unique symptoms and listening to their bodies and advocating for their well-being in partnership with their healthcare providers. We are also empowering more women to be part of research and to share their data and experiences so that we can create a body of evidence that will help us with our scientists discover new outcomes to ensure longer, healthier futures for the individuals and for society. You may not be aware that the United States has the worst maternal mortality rates in the developed world. Over 700 new moms lose their life every single year. Cardiovascular disease is the leading cause, and Black and Native American, Alaskan Native women bear the brunt of this horrible statistic, suffering disproportionately from adverse maternal health outcomes. In fact, they are 2 to 3 times more likely to die from pregnancy-related complications in comparison to white women. As long-standing champions for health equity, the American Heart Association is more determined than ever to leverage our voice, our platform, and our resources to identify and remove barriers that prevent all people from living healthy lives. Tonight, you will hear from experts and community members who will share solutions for overcoming these startling statistics, and they'll give us their thoughts on how to build resilience in our ever-changing world. I have no doubt that the conversation will be a catalyst for ongoing opportunities to address these challenges, and we invite each of you to share what you learned tonight with the women in your lives. Losing even one woman to cardiovascular disease is too many. Thank you for joining us today, and Pamela, back to you.
Thank you so much, Nancy. Tonight, we have convened a powerful group of voices to share their expert advice and personal stories. It is my honor to introduce our moderator for the next hour of conversation, along with our panel. Candy Castleberry is the VP Diversity, Partnership Strategy and Engagement at Twitter, and a longtime AHA volunteer. I remember when you came on board, Candy. After earning an MBA from Pepperdine University, Candy worked in diversity initiatives at Motorola, Xerox, and the University of Pittsburgh Medical Center, a global health system with more than 80,000 employees. While at UPMC, she became passionate about helping erase health disparities in healthcare. As an active AHA volunteer locally and nationally, Candy has served on the American Heart Association's Diversity Leadership Committee and is currently a member of the Go Red for Women National Leadership Council. Thank you, Candy. Dr. Stacey Rosen is a practicing cardiologist as well as Senior Vice President for the Katz Institute for Women's Health, which focuses on the elimination of healthcare disparities through comprehensive clinical programs, gender-based research, community partnerships, and education, and partner council professor of women's health and professor of cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. She is a volunteer for the American Heart Association with leaderships at both the local, regional, and national levels, among other organizations. Dr. Rosen was recently recognized as the 2021 Physician of the Year for the American Heart Association. Congratulations, Dr. Rosen. You deserve that honor. Dr. Nevins is a clinical solutions medical director responsible for the New York, New Jersey region at Aetna, a CVS health company. She is a board certified obstetrician and gynecologist. During her time at Aetna, she served on the National Quality Forum Standing Committee on Perinatal and Reproductive Health, the organization that reviews and outlines the quality measures used by our nation's hospitals. In addition, she collaborated with the National Governors Associations for best practices to develop recommendations to reduce perinatal morbidity in the state of New Jersey. Her passion for consumer health education and wellness has been consistent and has colored her roles as both a physician and a clinical executive. She fervently believes that health education is a critical tool that can change behavior, improve the health of individuals, and facilitate intact communities. Thank you. Dr. Rachel M. Bond is a women's heart health and prevention specialist devoted to expert diagnosis and treatment for improved patient outcomes. Her expertise is in cardiovascular disease with special interest in women's heart health, prevention, lipid disorders, pregnancy-related heart disease, cardio-oncology, and autoimmune-related heart disease. Dr. Bond is a board-certified attending cardiologist and the systems director of the Women's Heart Health Program at Dignity Health in Arizona. She is affiliated with the Chandler Regional Medical Center and Mercy Gilbert Medical Center. Thank you. Dr. Brian Thompson from Upstate Medical University is a board-certified in obstetrics and gynecology and a citizen of the Oneida Indian Nation of New York. Among his clinical interests, Dr. Thompson focuses on Native American healthcare and underserved patient populations. He is also a member of the New York State Maternal Mortality Review Board and a member of various patient safety and quality committees. Thank you. And finally, Eleni Z. Segas is the CEO of the Preeclampsia Foundation, the National Patient Advocacy Organization for Hypertensive Disorders of Pregnancy. Eleni is a relentless champion for the improvement of patient and provider education for empowering patients to be catalysts in scientific advancements and innovations in healthcare practices, and for keeping the patient voice centered in all that we do. That is so important. She has advised and collaborated with many organizations, including the World Health Organization and the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, and the National Institutes of Health. Most importantly, she is a two-time survivor of severe preeclampsia. Welcome to each of you, and thank you for your time this evening. I will now turn this program over to Candy. Candy?
Good evening, and thank you, Pamela. It has been and is always a pleasure to work with you, to be in the company of you, and to some degree, I would say, to work for you as a volunteer. Tonight, we are having an important conversation. So it's my honor to be a part of it, and I'm thrilled to join each of you. We're going to have an open and honest conversation about the importance of health surrounding pregnancy, maternal mortality, and why an equity gap exists. So let's start with the biggest question. What is the connection between pregnancy and heart disease? And Dr. Rosen, if it's all right, let's start with you.
Thanks, Candy, and thank you all for including me tonight. We're a complicated situation, but actually a simple answer. The connection starts with the fact that cardiovascular disease is the leading cause of maternal mortality in the United States. And as you just heard, the US ranks dead last among developing countries in maternal mortality. Aside from maternal mortality, maternal morbidity, meaning bad clinical outcomes, is also a tremendous problem because many of the cardiovascular diseases that occur during a woman's pregnancies actually have an impact on her life long term, even after the delivery of the child. And that's something that previously we didn't really appreciate. 10 to 20% of women will have a health outcome during a pregnancy, and that's enormous. And finally, like other cardiovascular conditions, the issue of maternal morbidity and mortality is one plagued by health inequities. based on race, ethnicity, access to care, access to healthy foods, and other social determinants of health. So for cardiovascular prevention, for advocacy, for research, it's a really sweet spot for us to be in tonight.
Would anyone else like to join or into the answer, or should we just go on to the next question?
I was wondering, I'd love one of the doctors to sort of add this additional note to what Stacy said, but I think a lot of people don't realize that during pregnancy, our vasculature is so much more fragile, and things like blood pressure, risk of stroke, and those kinds of things are just so much more, they're closer, and we really need to be a lot more tuned into our vasculature and our cardiovascular system. And a lot of people don't appreciate that, because if a woman shows up in an emergency room and she's treated like a non-pregnant woman, disasters can happen.
Lenny, it's funny you should say that, because any of us who deal like Rachel does and I in cardio obstetrics, we talk about what goes on in pregnancy as a cardiovascular stress test. The blood volume is up, the hormones that affect the way the heart and the blood vessels respond are altered. The placenta is an enormous vascular organ, actually. And so there's so much that we learn about cardiac anatomy and physiology in the 3 and then even 4 trimesters of pregnancy.
And I can also imagine that sometimes during pregnancy, you have an age where you're probably not thinking much about heart health. And sometimes I think that can end up, being one of the challenges when you don't connect these two. So I'm just grateful that we're having this conversation, and that hopefully the things people are hearing, they take out to all of their friends and family, because this is a real conversation.
Candy, I'm just going to chime in very briefly just to add that, it's really important for us not to overly attribute symptoms to pregnancy, right? We know people will become short of breath. That could be due to physiological changes, as was mentioned, or sort of changes in terms of the anatomy and the increase in girth. But we do need to be attuned and attentive and careful not to overly attribute changes, palpitations, shortness of breath to pregnancy, and report those symptoms to our provider so that we can make sure that everything's okay.
Yeah, thank you for that. All right, well, let's now talk about the women who are most impacted. Pregnancy-related deaths in the US are rising, unfortunately, at an alarming rate. We now have cardiovascular disease as the leading cause. Between 1987 and 2015, pregnancy-related deaths rose by 140%. Racial and ethnic disparities in pregnancy-related mortality are significant. They're peaking among Black non-Hispanic women, followed by American Indian, Alaskan Native, non-Hispanic women. Why do communities of color, I want to say, it says to bear, but why do we continue, right, to bear the burden of maternal mortality? And maybe we'll start this time with Dr. Bond.
Yes, thank you. Thank you again for the opportunity. I think this is such an important question, and it's, I think, a question that has a lot of different answers. One being that even if we look back in the introductory slide, they commented the fact that there are the top 4 risk factors for maternal mortality, one being age. We know that moms now are having babies later on in life, so the older you are, the higher your risk. The other one was elevated blood pressure. The other one was obesity. And then the last was race. And I can say that when we think about race, we know that the over-reliance of race from a genetic and biological perspective is unfortunately leading to us undervaluing the actual social aspects of race. As Dr. Rosen very nicely mentioned, the equity that we're seeing, or inequity thereof, has a lot to do with those social determinants, where we were raised, where we grew up, where we live, and what access we have, not just to quality healthcare, but actually continuous healthcare, making sure that there are not gaps in care, a lot of which we see in these communities of color. And at the central core of this, we have to highlight the fact that racism is leading the way. And that, I think, is a more powerful statement for us. Instead of saying that it's race, ethnicity, it's actually the social aspects, which is racism, that's leading to these higher rates of maternal morbidity and mortality in women of color, specifically in the Black and Brown communities.
Yeah. And I'm going to echo that. I mean, I read something recently, and I think it was nicely stated that the social and economic injustices definitely put Black and Brown women on a trajectory that is disparate from that of their white counterparts. Mm-hmm. And the argument becomes circuitous, right? We enter pregnancy with more chronic disease burden, but those chronic disease burdens are being caused by our zip code, essentially, in terms of, diet, exercise, air, access to healthcare, in terms of literally distance and lack of transportation, for example, to potentially getting to situations or institutions that may be better resourced to deal with those compounded issues. Mm-hmm. So I would definitely, I think you said it very nicely. It's not race, it's racism. And I think that's something that hopefully we can take away from this conversation, so that we're focusing our intervention and the policy changes that we need to make in the right direction.
Dr. Nevins, and then I'm going to go over to Dr. Thompson. Blood pressure. How does blood pressure impact this conversation? How is having high blood pressure in those communities that experience that? You want to add anything around high blood pressure?
So certainly, if you're going, we always focus on the two things that increases your risk of gestational disease, and that's pre-gestational hypertension or high blood pressure that exists before becoming pregnancy, and certainly diabetes and obesity. All of those, increases your risk of developing hypertensive disease in pregnancy. So without getting too far ahead in the conversation, it's really important to address the mom preconceptually, if you will, and really make sure that these conditions are well managed or mitigated as much as possible before we enter pregnancy.
Thank you. Dr. Thompson, do you want to add anything about communities of color bearing the burden of maternal mortality?
Oh, absolutely. So I'll talk a little bit for a minute about the Native American community. I'm Native American from Oneida. And, I think it was said very well when we talk about racism, but that systemic barriers to care. When you look at specifically Native American communities itself that live in these incredibly isolated areas, you're looking at issues of what we call historical trauma. We look at issues of chronic disease, diabetes is so much higher in the Native American population, hypertension, incredible amounts of poverty, and really trust in the system itself. But the biggest thing sometimes when we talk about Native American communities is just lack of access to care. And when we talk about lack of access to care, we're talking about healthcare funding. So I just like to kind of make the audience aware a little bit of, if you're Native American, you're cared for by the Indian Health Service. It's a federal program. And if you look at what the average healthcare spending is in the United States for someone who has, and these are very common words, Medicare. The average Medicare funding in the United States for a person is about $13,000 a year. If you look at Medicaid, it's about $8,000 a year. And we've all heard about the problems with the Veterans Administration, veteran care. That's about $9,500 a year. But for Native Americans, their healthcare spending per person in the United States in 2018 was $3,779. So you think about that a little bit. A half of Medicaid, less than half of veterans, a third of Medicare. And we're talking about incredible healthcare deserts. We talk about food deserts and food instability. We have a crisis in the Native American country of dealing with healthcare funding. And one thing that hadn't been mentioned yet is that really perinatal care, prenatal care really starts preconceptually. It starts prior to pregnancy itself. And if you look at Native Americans who have incredible rates of diabetes and moms who give birth when they're diabetic, they have increased risks of birth defects of the heart itself that go undiagnosed with lack of access. And for the Native American population, only about 3 to 4 times higher percentage of Native American patients get their care starting in the 3rd trimester when you're getting ready.
Wow, this is really shocking. And I would say personally, and I hope that the audience feels the same way, that we greatly appreciate your transparency. These aren't easy and comfortable topics, but the only way that we get better as individuals, as communities, and as an organization committed to addressing heart disease and reducing it is by having these conversations. So although it's shocking and you're being very transparent, this is how we move forward, is thinking about how we have these conversations and take action from it. So I'm going to go back to Dr. Nevins. You mentioned the conversation around blood pressure. And I just want to add that studies have found that pregnancy complications, including high blood pressure, gestational diabetes, preterm births, and small gestational ages at birth deliveries occur in 10% to 20% of all pregnancies in the US. So I'd like to maybe have a conversation about preeclampsia and what is it and what are the signs? And maybe we can start with Eleni.
Absolutely. Thank you, Candy. Yeah, I think a lot of people, I fully appreciated the stories that led off this series. Many of those, I think almost all those women suffered from PPCM, peripartum cardiomyopathy, which is definitely an acute and very serious situation. What a lot of people don't realize is that preeclampsia and sort of the whole spectrum of what we call hypertensive disorders of pregnancy can affect anywhere from 1 in 20 down to 1 in 12 pregnancies. So we're talking about a condition that is, I wouldn't consider that rare. That's relatively common to see. I don't think you could get into a crowd of women and not ask and say who had some kind of hypertension issue in their pregnancy, and somebody's going to raise their hand. Now, fortunately, we've gotten much better at preventing these women from dying. Not that it doesn't happen, it does. There's been some really high profile cases where women have died from preeclampsia and related conditions. But there's a lot of morbidity. We heard that term earlier, basically adverse pregnancy outcomes that can come from having high blood pressure in pregnancy. And a lot of people think that the high blood pressure is the disease or the disorder. In the case of preeclampsia, it's really one of the signs of having preeclampsia. And it's why, frankly, it's why when you go for a prenatal visit, the 3 things that happen is you pee in a cup, you take your blood pressure, and you get on a scale, because they're looking for preeclampsia. So one of the things that is so important to understand is that it's not just the blood pressure. There's this constellation of symptoms that may be occurring with it. And as Dr. Nevins pointed out, the symptoms may or may not be bad, or they may or may not be indicators of something bad, but they are things like having a headache that won't go away, or visual disturbances like an aura or seeing spots. What's called epigastric pain, which is pain in the upper right quadrant of your abdomen. Excessive swelling in the upper extremities, so like around the eyes and the hands. Feeling nauseous and throwing up late in pregnancy, so not the early morning sickness nausea, and gaining weight quickly, like more than 5 pounds in a week. All of these are considered symptoms of preeclampsia, none of which alone would cause a doctor or midwife to diagnose it. But it's enough of a concern that women need to report it. They need to see their healthcare provider and talk about some of these symptoms. And as I mentioned earlier, the signs, primarily blood pressure going up, is also very important. And it's really for these reasons that we are very passionate about patient education around this topic, because it's not rare. A lot of women may have this. The symptoms may not be specific to preeclampsia, so they really need to be checked out. And frankly, by providing patient education, you're really giving that woman more agency over her body, right? We talk about the patient-provider relationship, that I always say, like, the provider is bringing medical knowledge, medical expertise to the table. I know my body better than you do. I'm bringing that knowledge to the table. So if I can be empowered with more information about my body, it gives me a vocabulary to express my concerns. And frankly, I need to be listened to about those concerns. So, when we talk a little bit, and maybe we'll get to this a little bit later, but we talk a lot about the 3 deadly Ds. And one of them is dismissal. And that's when providers are dismissing patients who are coming with these concerns, either around blood pressure or one of these symptoms. So it's very important that women know and understand the signs and symptoms of a relatively common and very dangerous disorder, dangerous to them and to their babies.
You delineated that so beautifully. I'm so proud of you. It was beautiful.
I do this
it was
occasionally,
perfect.
right?
And so I just want to add, it is a creepy disease. It is insidious. You have to look for it in everyone. And you may be okay on Monday, and then on Wednesday your blood pressure is up. Your headache may start as low grade, and then it gets to a point where it's not going away. So you do need to let people know. You do need to be aware of it, acknowledge it, don't poo-poo it, and you need to tell someone. And to Elena's point, hopefully you have a provider who's going to listen and pay attention. And I learned that lesson as a resident. I had a teenager, she's having all these weird pains. I'm ordering CAT scan, MRIs, and the chief of my department, Dr. Ludmere, said, it's preeclampsia. He kept saying, it's preeclampsia, Juliet, it's preeclampsia. And then finally, like on the second day, her labs came back, and, all of the symptoms and everything, came together. So it is really a creepy disease, but it is deadly because it sort of glides along that spectrum, and it can get to a point where, patients are now very ill in the ICU, potentially seizing, potentially abrupting, which is when the placenta separates from the uterus. And people don't understand that it can get to that point where it's dangerous very quickly. So I love the messaging and how important it is to pay attention to symptoms that we would dub as vague, right? And just to keep pressing forward if you really feel that you're not feeling well and something is wrong.
Well, and I'm sorry, Candy.
No, you go ahead. No, you go ahead.
I was just going to say, I think that I know most of the doctors on this panel, and I think that they would all agree that one of the most important things that we can do is get blood pressure cuffs into the hands of women and teach them how to use them properly. So, because frankly, there can be a big gap between prenatal visits. And as you mentioned, things can go south really quickly. I often joke and say that, mom and her family may often be the first responder to a crisis brewing. So things like making sure you've got a blood pressure cuff, you know how to use it, you're aware of the symptoms, you know who to report that to, will really support you being your own best advocate.
Yeah, my sister had a child later in life And there were lots of concerns because of her blood pressure. She was 44 when she had her last child. And one of the things, fortunately, is she had a doctor who monitored and made sure she monitored her blood pressure. And that also, I think, helped to plan or to influence the plan for her delivery, because they had to monitor her blood pressure. Since we have, we're talking about complications, I wonder, Dr. Nevins, if you can tell us a little bit more about perhaps any other pregnancy complications, risk factors, and who is most likely to experience these complications during pregnancy.
Right. So certainly we talked about the cardiovascular diseases, the cardiomyopathy, where we need to add to that thrombotic disease. That's where you get a clot in your leg that can potentially travel to the lungs. And we've already just sort of gone through the hypertensive diseases. But we also need to be mindful of bleeding, right? In terms of, and that can cause morbidity in terms of needing multiple blood products, multiple transfusions, potential operations or reoperations that then can lead to other clinical sequelae. So I would say those are the four big categories: bleeding, cardiovascular diseases, including blood clots, and we can't forget about infections. And all of these, you know, there was a study, 75% of these outcomes are preventable, but you need to, again, you know, the dismissal, be able to report it in a timely manner so that we can intervene at a point where we can reverse the situation, as opposed to, you know, chasing the snowball as it's rolling down the hill. For African American women, certainly the hypertensive disease categories are most prominent. You have other, like the Asian community, they tend to have more bleeding complications, for example. The infection, it's not necessarily that African Americans are more likely to become infected, but they are at risk for reporting the infection late or being diagnosed at a later stage in the infectious process, which contributes to morbidity, the illness, and potentially, you know, mortality, unfortunately.
I often think about this question, and I don't know if not being a physician, like if I'm just a person in the audience, like my thought is I'm young, I'm healthy, and I'm going to have it. Clearly, I'm not talking about myself. And I'm planning to have a child. I've never had really any complications. I think that sometimes when we're having these conversations, we're talking to people who have some knowledge of this. Mm-hmm. I think that it's also really important to think about healthy people who are pregnant or who were healthy before they became pregnant. And so it's easy for them to associate, as someone mentioned earlier, this is a symptom of pregnancy as opposed to something I should be concerned about. So is there an age group that is it's healthy? I mean, that is impacted more than other age groups. I know my sister, being a little bit older, had, you know, some special things that she had to do because she was pregnant at an older age. I also have a sister who's an OBGYN, so my sister had always a coach in her ear, but most people don't have that. And having a healthcare advocate, having a relationship with people who can provide that information is sometimes the thing that helps guide you. But what advice or recommendations would you give to someone who's young and healthy and pregnant for the first time?
So I'm going to say they're young, they assume they're healthy. And Dr. Rosen, you're tickled. So
I sparked something there.
Right? They assume they're healthy.
So the analogy we use, Dr. Nevins, is, you know, I'd never presume to wake up tomorrow and run a marathon. Mm-hmm. I can be 19 years old and you know, be a mid-distance runner, and I would never do that. So the importance of preparing before a marathon is every runner's, you know, simple truth. And the truth is, pregnancy is the equivalent of a whole bunch of marathons in a row. And it's often the first time that a woman gets to develop a really strong relationship with a clinician. I mean, data has shown that we're more successful getting women to stop smoking during pregnancy because they're seeing a clinician regularly and, you know, potentially staying off. So that relationship and sort of doing everything we can to say, well, I'm young, but let me make sure, let me get my family history. Let me make sure that 135 over 90 is not borderline. And to really, you know, before you strap your sneakers on and get running for a marathon, that you really make the relationship and you make sure you're ready to run.
And I wanted to assume you're healthy, because a lot of people assume they're healthy because they're young, right? But they have crazy hypertension undiagnosed, crazy high, you know, the cholesterol is, you know, out the roof. So, I mean, it's about preparing and having a relationship, talking about your family history, talking about your current health condition. You know, what is your diet? What is your environment? What is your stress level? Are you sort of getting care for your mental health? Because I'm going to circle back to the conversation at the top of this meeting around the cumulative impact of racism, and that it is real and that it certainly takes a toll. Now, if you acknowledge and you're aware of the social determinants of health, then there is some intervention that you can do on an individual level. You may not be able to go to Whole Foods every week because of where you live, but what can you do? What small changes that can you do that might be impactful? You know, can you manage your weight better? Can you make sure that you're getting counseling if that's something is needed? Did you talk to your doctor about using an aspirin during pregnancy to reduce your risk of preeclampsia? Have you checked your blood pressure? Do you even know what it is? And I'm going to stop, but I also wanted to add that whenever we talk about morbidity and mortality in the Black and Brown communities, we always assume that this is relegated to the Medicaid space or to women who are unduly impacted by social determinants of health. And in fact, when you normalize for demographics, Black and Brown women are still at risk. So one of the things that we definitely need to sort of harp is that we need to have a tiered and multi-pronged approach in terms of national policies, in terms of policies at the level of the hospital, in terms of making sure that how we engage with patients is, is equitable and fair, making sure that we're having discussions about bias with our providers, because we can't put the onus on the individual patients to reverse, all of these problems. There are different levels of accountability, and at different levels, there needs to be intervention and action.
Yeah, and if I just may interject also, and thank you all for all of your thoughtful statements. I agree with each and every one of them. One thing I do want to emphasize is a lot of these younger women that are getting pregnant do not, as Dr. Rosen very nicely said, see clinicians on a regular basis. So I really emphasize the importance of that preconception counseling period, because that's when we can look for all of these chronic, possibly chronic medical conditions that do place them at a higher risk for adverse outcomes, blood pressure issues, diabetes, possibly even if they're overweight or obese. And, you had asked the question earlier, is there an age when moms should start to worry because they're at a heightened risk? And, we know that advanced maternal age, of course, is something that does predispose you to future complications or complications during your pregnancy. And that's usually anyone above the age of 35. And that's where we may have that conversation to say, maybe you do need that closer follow through during your pregnancy, during that prenatal stage, where maybe not just seeing an obstetrician, but maybe seeing a higher risk obstetrician, labeled a maternal fetal medicine doctor, perhaps even seeing a cardiologist like myself or Dr. Rosen as an example. But I can't emphasize enough the importance of that preconception period, because that's really where we can delve into all of those risks, including those social determinants that I think we as clinicians have to do a better job at in terms of actually asking the questions and hopefully coming up with sound solutions for them.
So since I have you, Dr. Bond, are there other strategies that you think or that you'd like to share that have worked to help address some of the barriers? And what needs to happen to improve maternal health outcomes in our communities?
Yeah, I think we've highlighted so many of them, but I do echo Dr. Nevin's sentiment from a legislative level that we really have to pass a lot of the bills that are currently in place. I think I am so hopeful for this new administration in the sense that they are taking maternal health absolutely very seriously. Even during the Black Maternal Health Week, they emphasize that it's going to be moving forward a week where we actually acknowledge that there is an epidemic. And I think that when it comes to a lot of the legislation that is currently in place, we have the Black Maternal Momnibus as an example. And that, I think, gives a really wonderful overview of what everything we're talking about. How do we tackle those social determinants, not again just focusing in on the genetic aspects of things and the medical aspects, but really those social determinants that are at the core of it. If we can do that, then I think that we're going to provide guidance for us at a more local level, health systems, clinicians, getting that proper training, including implicit bias or unconscious bias training, which we absolutely have to do in medical school as well as our training during residency and fellowship and beyond. And I think that that's going to hopefully allow us to highlight the issues and the core of what the issue is.
Yeah, thank you for that.
I'd also like to just say something real quick. Also, when you look at a number of these communities, like the Native American community or other communities of color, invisibility is one of the worst forms of racism. And we look at a lot of our patients and they're invisible in the aspect that, for example, during COVID, a number of patients weren't able to have an advocate with them. They came to their appointments alone. And a number of these were younger patients, mental health issues itself. And then we have workforce issues. And I'll say again for the Native American population, in the Indian Health Service, about 25 to 30% of healthcare providers are lacking for Native American healthcare. Can you imagine going to your hospital, going to your practice or anywhere else where 25 to 30% of providers are not existent? It's just incredible. But also too, I just wanted to say one thing is when in my language, when I meet somebody, I say Sagoli. That means I see you.
Say that again and a little louder.
Sagoli. That means I see you. So I see you. And it doesn't mean I just see you like a hello, I see you. It means that I respect you and I embrace you. So as a healthcare provider, as an OBGYN, our most important function is listening to patients. And it's not just listening to patients, especially with our patients of color. It's being intentional in the questions that we ask. It's looking for cardiac diseases. It's looking for risk factors, such as mental health type issues. It's looking for preterm labor and the symptoms of it, and diabetes itself. So being intentional is such an important aspect of healthcare.
Can I add something to that, Candy? Because I just want to add an exclamation point to everything Brian just said. And I just want to also encourage us to think about this. And we're talking about pregnancy right now, and hopefully we're also thinking about the postpartum period. But everything we're talking about, and this has got to resonate with the American Heart Association, is the idea that all of these issues that are hypertensive and cardiovascular nature are a window into that woman's future health. And having that really important conversation with her about what does this mean for you for the future? And I'm not talking like postmenopausal future, I'm talking the near-term future. And that whole beyond pregnancy listening to her, giving her the information and education she needs, encouraging her with and supporting her with the health tools that she needs to address her higher risk for cardiovascular disease is so critical.
I am going to just say, before we move away from this, that I want to make sure that I'm saying, is it Segoli? I'm going to go back to Dr. Thompson.
Yeah, so in where I'm from in Oneida, we don't have a word for hello.
You don't have a word for love?
We don't have a word for hello or a word for goodbye, but we say Segoli. And what the closest is of that is that when I meet you, is that I see you. So imagine this, I see you. And it's not that I just see you as a physical person, but I see every part of you. I respect you. I see your social determinants. I see your situation. I see how much work it came for have you come to see me in the office. For some of my patients, they need to walk. Some of them need to take a cab. Some of them need to take a bus. Some of them need to have somebody bring them there. So I see all of those issues and all of those problems that you bring to the table. I may only have 15 minutes with you in the office, but I want to know as much as I can, find out about you. And not only that, the simple things as an OB is maybe just to follow up with your patients by a telephone call or a nursing call, to keep a close eye on them, to care for them like they're your own sister, your own mom, or your daughter. So I see you.
Segoli, I see you. I see all of you. We're going to take a couple more questions and then we're going to wrap up. But I'm taking away from this. I'm obviously not a physician, and although I have been committed to AHA, I have a sister who obviously deals with this as a regular basis as an OBGYN, and then I learned a new term. My other sister had advanced maternal health or something like that, along the terms of having a child at an older age. I do think that these conversations need to obviously happen beyond the conversations of the choir, right? We are the people who understand and are committed to learning and growing and seeing other people for what they bring into the doctor's office and all the challenges that exist around them. So let's talk about what happens after pregnancy. Many heart-related problems can come in the days or weeks after delivery, up to 1 year. What symptoms should women know to look for to indicate problems or that something isn't right? How about we start with Dr. Nevins?
Yeah, you know, I always start with headache. You know, especially if you were treated for preeclampsia, you know, while you were in the hospital, you deliver, we've gotten your blood pressure down or your blood pressure has come down on its own. You know, if you go home and you have a persistent headache that does not resolve with 2 Tylenols, for example, you know, I need a call, I need you to come back into the office for a blood pressure check. Patients who have preeclampsia need to have, you know, 1 and 2 week postpartum visits anyway. But certainly, you know, the headache is a fundamental symptom that we have patients watch for. Blurred vision, you know, Alina delineated a lot of this, and dizziness. The other very important one, and this is what I meant, and this is what I was thinking of when I tell patients, don't attribute, you know, certain symptoms just to the pregnancy or postpartum period. Shortness of breath, right? Patients go home, maybe they've had a C-section, maybe they're going home to 2 and 3 children, so they're more active, and they ignore, or they're anemic, right? But they ignore persistent shortness of breath, which could be a blood clot, a PE. It could be cardiomyopathy. It could be pulmonary edema, where your lungs are filling up with fluid because your preeclampsia hasn't resolved. So a lot of people die because they're walking around short of breath and they haven't told a soul. They just assume, I just had a baby, I'm exhausted. So this is what I mean about being really attuned to how you're feeling. You know, I did a series of forums for my company where we talked to colleagues in CVS who were of color about their birth experiences. And one woman simply said, I just felt like I was going to die. She did not have a specific symptom, right? So I'm really trying to stress that if you don't feel well, say something, right? Call. It's better to go in and get checked out. And it may be that you need a mental health visit, which is equally important, right? So if you don't feel well, definitely say something. And certainly, Elena, you had mentioned sort of right-sided pain, the swelling. Everyone has swelling, and it should resolve in about 1 to 2 weeks. But if it's sort of in your neck and your face, that's a little bit more worrisome, especially if you don't notice that it's going away. So those are some general areas that patients should sort of look for, you know, once they leave the hospital, with respect to the potential need of additional healthcare intervention.
Eleni, do you want to add anything else? You always come in on the back end and put a period or an exclamation point. So we want to give you an opportunity to do that.
This is a subject that I'm extremely passionate about. You know, one of the things when you look at recent data on maternal mortality, one of the things that we're learning is that we're doing better in the hospital. Patients aren't going to the hospital to die anymore. Where the problems are what happens before they arrive at the hospital and what happens afterwards. So I cannot underscore enough how important it is that mom and her support system go home with really sound information and a plan. What do I do in the next few days if XYZ happens? What do I do in the next couple weeks? You know, this myth of delivery is the cure for preeclampsia. That is a myth. There is the worst outcomes happen postpartum. But then there's 2 weeks out, 6 weeks out, months out. One of the things that surprises survivors is that their hypertension doesn't resolve right away all the time. It may unmask what is now chronic hypertension for them. So this whole idea of like, what am I doing beyond this pregnancy to get healthy for this baby that I just birthed, for my family, for myself, is so, so important. And really, this is where the synergies with the cardio obstetrics world is huge, because we really need to be paying more attention to mom's physical and mental. Cannot underscore that enough. You come through a pregnancy trauma, like some of the things we're talking about, those women we saw at the beginning of the hour, mental health help is needed when you've come through traumas like that.
And I want to underscore something, because we have sort of alluded to it during the discussion, that if you're diagnosed with diabetes in pregnancy, it's very telling of your risk later on. If you're diagnosed with a cardiovascular disease in pregnancy, you need to, ask about this. When you're 50, tell your medical doctor that when you were 25, you had preeclampsia. It portends a different potential prognosis. And Stacy, you can steer me back on track if I'm wrong. And it's important for women to know that preeclampsia, Elena, is the window to your future cardiovascular health, and your doctor needs to be aware, because those, we have electronic medical records that don't talk to each other. So your primary care doctor who sees you 10 years after you've had a baby may not know and may not think to ask. So this is where patients can advocate for themselves, and we're helping them do that tonight by giving them this sort of information.
Dr. Nevins, I always get a giggle when I ask a new 5-year-old patient about her pregnancies. They usually look and say, Stacy, my kids are older than you. Why are you asking? And I'm like, tell me, has nobody asked you this? And that is spot on advice.
Well, Dr. Rosen, since I have you and we're about to wrap up, why don't, if you're, you perhaps and Dr. Bond, maybe give us one tip about the long-term impact on women's healthcare and what every woman should know. So if we can just do that very quickly, and then we will wrap up. One tip What should every woman know that we haven't already covered? It's not a trick question.
Oh, me first? Okay. I think that this is the time in your life to become a fierce advocate for your own health. I always, smile. Mothers will lay down in front of, railroad tracks for their children, but they really need to advocate for their health. And over, 30 years of practice, I know that women have this sixth sense of when something's not right, and you really need to act on that. As everybody said, don't assume it's from, oh, I'm just pregnant. Don't assume it's just that I'm tired. I'm the mother of 3. Every time you don't think something's right, call your clinician and act on it.
All right, Dr. Rosen, thank you. Dr. Bond,
Yeah,
one last tip.
Absolutely. So I echo that advocacy is a large part of this. We talked a lot about the fact that we're not doing a good job in terms of listening to these mothers. And I think that for us, even as clinicians and those in the community, we have to do a better job at listening, not just listening, but believing the signs and symptoms. And for those in the audience, in the community, if you're feeling something that's not right and it's perseverating and continuing on, you have to trust your gut, talk to your doctor. And if your doctor or clinician are not listening, always feel that you can get a second, third, and or fourth opinion, because we want to make sure that you're at the end of the day taking care of yourself. So that's what I would leave you with.
All right, one last tip, Eleni.
I've already hogged too much time on this. I will say that sending mom home from the hospital after an adverse pregnancy outcome with a 1-page, not her stack of medical records, but with a 1-page summary of what actually happened to her is going to enable her to do some of the things that you just heard as far as advocating for herself, and will help future healthcare providers care for her.
Okay, and Dr. Nevins, one last tip for the road.
The tip I have is for us. Brian, I hear you. I worked for a federally qualified health center. The doctor alone cannot solve these social determinants of health. So I appreciate the American Heart Association and all the entities that are going to impress upon our politicians to have more equitable distribution of resources to all mothers.
And finally, Brian, Dr. Brian Thompson.
I echo
last tip for the road.
Here's my last tip: is everything that's been said is perfect. I just want to say thank you to the American Heart Association for this amazing webinar, and to everybody that's on here. I'll just say Onagiwa, which means in my language not goodbye. It means until I see you again, which means I will see you again.
Onagiba.
Onagiba. As tonight comes to an end, I want to thank this excellent panel for this amazing information. This was an important conversation and timely. I encourage each of you, whether you're considering becoming pregnant, are pregnant, or have already had children, to care for yourself. Be aware of your personal risk factors and incorporate healthy changes into your lifestyle. And please, if you have specific concerns, seek help from a licensed medical health professional. Please know that you can find additional information, as always, at goredforwomen.org/pregnancy. We've been given each day to use as we will. We can waste it or use it for good. When tomorrow comes, this day will be gone forever, and in its place are the decisions that we left behind. I want to thank you for making one decision to join us tonight. And I'd like to ask you to make a decision to do something for yourself, whether you are pregnant, helping someone who's pregnant, and also to do something for others, because the world only gets better when we see each other. Thank you, Pamela, and I will hand it over to you.
Well, thank you so much. And what an incredible panel and discussion. And I walked away with some sound bites that I just have to restate, because if you could see the chat on YouTube, I feel like I'm compelled to restate them. So one is around systemic barriers of care, trauma, lack of access to care, transportation, but most importantly, the word invisibility, not being seen. That was powerful, Dr. Thompson. And I just wanted to bring that forward because there was a lot of chat about that word. And then also understanding the disparity that exists with the amount of money spent per patient in the Native American population was alarming and deplorable. So appreciate that statistic. And there is much work to be done there. And then the 3 Ds, dismissal, denial, and delay. Being able to recognize though and to take action. And then the fact that we are empowered to make small changes. You know, I always say we can't boil the ocean, just do one thing. Don't try to do 10, just one. And that is walking, making a healthier choice when it comes to food, or if it's meditating, focusing on yourself, just having a mental health day, just take that one small step. And that leads to many others. And then also, understanding the importance of equitable policies, being a patient advocate, being a fierce advocate. I love that, being a fierce advocate. And then understanding the importance of health literacy. If we know more, we can do better, but we have to have that information. And then intentionality, being intentional about all that we do. And then Sagoli, I see you. I love that. I see you. And so I know that I have to close out with some specific comments and to tell you a few things. And that is, if you want to make a greater impact after hearing all that was shared tonight, please sign up for Research Goes Red. That is so important, because when you sign up for research, then you contribute to us making better choices and better options for us as we deal with different issues in our lives. And then also there is a new reproductive health survey. So please complete that as well. And so that helps us just to better understand and implement better strategies. And as we close, we heard the word high blood pressure, hypertension. I stopped counting how many times that we talked about hypertension and high blood pressure. But what I want to encourage you is that to join us on May the 17th for World Hypertension Day, because we're laser focused on that day about being able to manage your blood pressure through self-monitoring, being able to partner with your healthcare professional, and making sure that if you are prescribed some type of medication, if it doesn't make you feel good, then you go back to your healthcare professional until you find the one that does work. It is incumbent upon us to advocate for what is best for each of us. And then lastly, I just want to say good night, but in the words of Dr. Thompson, Awagabi, which is, I will see you again. Good night.